right. Thank you, Jonathan. Thank you guys for joining us today. This is our final CEO CFO webinar for that series that we started back in the fall. I'll turn it over to Jonathan to introduce our speaker, and then we'll if you have questions, I'll be watching the chat. Feel free to chat. Also, at the end, we'll have some time for questions. But thank you guys for joining us. When we originally planned this, we were hoping to be able to do in-person networking opportunities. That's still something we want to do in the future. We have a CEO email listserv. It's very underutilized, but if you'd like to join it or post on it, please let me know. I'll get you added. But again, thank you for joining us. And if you have any questions or if you have any ideas that you'd like to bounce off of us along these lines, please reach out to us. So with that said, Jonathan, I'll turn it back over to you.
Thank you very much. So my name is Jonathan Pamberg. I'm a principal at Stroudwater. Today, our presenter is actually going to be Opal Greenway. Opal is the head of our provider practice group. She's been with the firm nearly 6 years and has an extensive background working directly with practices, hospitals, clinics, rural health clinics, everything you can think of, from everything from optimization to contracts to fair market assessments. So she definitely brings a well-rounded expertise to this area. And today she's going to be focusing on specifically provider contracts and how those are changing in a current environment. So thank you.
Thanks, Jonathan, and welcome everyone to today's session. So as Jonathan said, we're going to be talking today about provider contracts. That's both your physicians and your advanced practice provider contracts that you may have, both employed, independent contractors, if you have a professional services agreement with them, medical directorships. We're going to be talking a little bit about all of those things. I think what we're going to be discussing is applicable to most of those types of contracts that you have with your providers. So specifically today, we're going to go over an overview of those contracts and kind of the regulations that apply to them. And we'll be talking about, many of you know, CMS made some significant changes in December and both the beginning and the end of the month that a lot of people have been scrambling to figure out what do we do about those CMS changes. And given COVID-19 and its impacts, how do we need to adjust our contracts? And realistically thinking about it from a perspective of, we need a compensation strategy for both today and tomorrow, rather than constantly being in a situation where we're trying to react. Can we set our contracts in a way that are more forward-looking rather than constantly playing catch-up? So let's start off talking about, why do our provider contracts matter? When we realize, just how much money we actually spend, and this is from a physician spend perspective, of just the salaries we pay directly to our employed physicians and also the professional service agreements that we have with physicians specifically, it's equal to about 5 to 10% of your net patient revenue. And we're expecting that number to grow significantly. The data that we had available for how much of this of your net patient revenue that this amounts to, for the most part, because we don't, of how things are categorized under contracts, oftentimes doesn't include the advanced practice provider agreements in there as well. So if you think about it, 10% of your net patient revenue is a significant chunk of your budget added to that advanced practice providers. It's something that we definitely, especially as a CFO, need to be monitoring. How are we spending this money? Are we getting a good ROI from it? Making sure you understand all the ins and outs of that is going to be critical for your overall organizational success. One of the important things that I try not to take for granted, that most people are familiar with the Stark requirements. There's 3 major requirements under the Stark and anti-kickback laws that pertain to provider contracts. I used to think that everybody knew these laws, but I recently had somebody at a hospital system, their general counsel asked me what the Stark law was. So I've stopped taking that for granted, and I like to go over it anytime I'm talking about physician contracts, because it is of some serious consequence. It does set what we're allowed to do with a lot of our provider contracts, and frankly, the law is not going anywhere anytime soon. So under Stark and anti-kickback requirements, you have 3 major requirements when it comes to a physician contract. That is that the contract is consistent with fair market value. And fair market value in this case is, what it really means is it's the general market value of the transaction as a result of bona fide bargaining between well-informed parties that are not otherwise in a position to generate business for each other. So that's a legal definition from it. But the part I want to emphasize is the fact that it's the result of bona fide bargaining. You can go and make an offer to a physician and they can counter, and you can have that back and forth and come out with a number and it be consistent with fair market value to reach both parties' needs, as long as it's not driven by, hey, I'm going to give you this much in exchange for this referral. It's not driven by the volume or the value of the referral. Some people think fair market value is specifically whatever MGMA or Sullivan-Cotter or AMGA say it is. The survey data can be indicative. It can be a very useful guideline, but it is not the definition of fair market value, which is, I think, an assumption that people incorrectly make on a regular basis. FARC also requires that the contract must be commercially reasonable, meaning that it furthers the legitimate business purpose, even if that legitimate business purpose does not result in profitability. Some people thought, well, obviously anything that doesn't have a positive contribution margin can't be commercially reasonable. The Office of the Inspector General has ruled several times that that is not the case, that those of us who have been in the hospital environment, recognize oftentimes our physician practices are going to be operating at a loss on a regular basis, and that does not mean that we are outside of the STAR compliance. What we do need to be careful of things that might not be commercially reasonable are things such as duplicative arrangements. When you have all three of your family medicine doctors all have medical directorships, realistically, how is it possible, if you think about it from a medical directorship and what that's trying to perform, those responsibilities, why would every physician need to be also a medical director for most of the hospitals that we're working for? Or if you have unreasonable compensation terms in there. If you have a cardiac surgeon who for some reason you decided to recruit to do all of 10 surgeries a year, but we're going to pay him $1 million, like in all likelihood, there's no way that's going to be commercially reasonable. But it does need to be commercially reasonable to meet the STARC requirements. It's not a matter of, well, MGMA survey says an orthopedic surgeon needs to be paid $500,000, and so therefore it must be commercially reasonable if you can't justify that you actually need an orthopedic surgeon or that you need a second or third orthopedic surgeon in your services. Right. And the last piece is the requirement with regards to volume or value. You know, the directed referral law rule is new this year, where we actually are allowed to use percentages or ratios of referrals in our physician contracts. However, it's still prohibited to make the existence of any compensation arrangement contingent on the number or the value of the referrals. So keep in mind, a lot of people got excited thinking that the STARC law changed and saying, oh, well, you can now use volume and value in a contract. That's not the case. It's just specifically with regards to, can you start saying, requiring your physicians to say, okay, you get this much compensation. However, we're going to require you to refer this percentage of your total referrals to our organization. You can't tie a specific value to that percentage. You say, okay, once you hit $1 million worth of referrals, then you get this amount, but you can do percentage and ratio requirements in your contracts this year. So why does STARC and anti-kickback matter? You know, a lot of people are like, okay, well, that's all that matters is people go after the big systems. We've been so busy with COVID, and there's no way they're still, you know, focusing on enforcing STARC and anti-kickback in today's current environment. We have much bigger fish to fry. Well, that's not necessarily the case. As you can see, these are just some recent ones, some as recent as beginning of February, where we still have lots of organizations that are having to do settlements related to the STARC and anti-kickback law. And we're actually expecting some of people who, will go over this a little bit more in a bit, with regard to the COVID waivers, people who have been misusing or misunderstanding the COVID waivers, who are going to end up having to do some of the STARC and anti-kickback settlements. When I look at this, you know, a lot of people, again, think this only applies to very large hospitals or large health systems. You know, a lot of people are familiar with the Toomey case or with Tenet having to pay hundreds of millions of dollars in penalties as a result of STARC and anti-kickback. And that oftentimes is for really intentional violations. And that's actually not the case. The vast majority of the money that's collected from anti-kickback statute violations as a result of STARC are actually technical violations. Somebody didn't have a contract documented properly. Somebody did not make sure it was commercially reasonable. Some people did not make sure that their payments actually matched up with what the contract required.
And those technical violations, frankly, get people in trouble far more than the very purposeful, shady deals. I left on here Cookeville Regional Medical Center, which I'm based in Nashville, Tennessee, so Cookeville's not far from me. Last February, had to pay $4.1 million right before getting hit by a tornado and right before COVID because of some stark technical violation with the cardiology group that they were working there. And the cardiologists were coming on a part-time basis. $4.1 million for a lot of the hospitals that we work with, that's their margin for the year. That might be more than their margin for that year. So when we think about why is this important, compliance is something that we can't just sniff at and say, well, since it's just a check the box type thing, I don't really have to worry about it. Because frankly, as a CFO, I don't want to put my organization at risk for something over that, frankly, oftentimes these technical violations are pretty easy to handle and deal with if you're going to actually have that good hygiene about it. So now that I've spent the morning, talking about what are the requirements and scaring you into thinking, oh my goodness, what's my compliance? So let's think about, okay, how do I get something in compliance with this? What is fair market value? And when I think about your contracts and you think about whether or not it's in compliance and you've decided, hey, I'm not just going to look at MGMA survey to figure it out. I really like to think about it from a perspective on my contracts of two pieces. It's both the physician and the provider, right? So you have to think about it in both of those buckets, and how is this compensation arrangement addressing both of those pieces? So when I say that, the provider is an individual. What is their experience? What is their training? Are they hyper specialized? Do they have additional responsibilities that they're going to bring in, and expertise that they're going to bring out? Are they going to pilot a new program? Are they somebody who is, hyper ambitious and they're going to do all that they need to do to get out into the market to grow a new service line, right? That personality, right? That individual person. Why are they specialized, subspecialized? Long-standing in the community? Is there, were they born and raised in your community where that if you can recruit them, you don't have to worry about recruitment for the next 20 years because, hey, they're going to build a practice there and they're not going to go anywhere? Individual. What is that individual worth? But then there's also the position itself. What is that position that you've been recruiting for? How long has it taken time to be able to fill that position? Does your community need it? Have you had significant wait times? Right, for that are happening in rural communities, that it's really hard, that we have this high disease incidence and we need a specialized type of oncologist to treat it. Being able to find that's really difficult. Are we having a lot of out migration? Do we need to be able to pay this person for the fact that we have a lot of seasonality where they're going to be really, really busy for 5 months out of the year and then slow the rest of the year? So thinking about it both the individual, the provider, that person themselves, and the position that they're filling. And how does our compensation appropriately account for both of those things? Not all orthopedics providers are the same. Not all family medicine providers are the same. So saying, on the one hand, we want to be fair and say, here's a compensation model that attracts, everybody and has these parameters around it. You want to have something that has flexibility to understand that not every provider is the same and not every provider has the same responsibilities. And so how can we be flexible within those terms to set what's truly fair market value, right? When it comes to bona fide bargaining, the reality is, for any of us who have negotiated on our own behalf for a contract, very rarely do two people negotiate for the exact same things, right? So how can we make sure we take that into consideration? So what are the compensation models that we're seeing right now that are addressing those? First off, we have individual physician compensation. Within rural communities, it's still very common to have set base salary, guaranteed compensation. And in a lot of the communities that I've worked with, that is set, it's guaranteed. While I would say best practice is actually to only have a set base salary guaranteed for 2 years, while you allow a new provider to ramp up and establish themselves in a market. It's supposed to take 18 to 24 months. Some people, I've seen a lot of contracts that are guaranteed for 5, 10 years, and it might just be because nobody's updated the contract or re-examined it. And so having that guaranteed compensation, while the most prevalent compensation in rural communities still, definitely I would say is not in line with best practice. And so if we're there, how do we move that forward? The next layer would be individual performance to actually determines compensation. Most of you know this as such as doing productivity-based incentive compensation, where work RVUs or patient visits or panel size of a provider are going to indicate it. They might have a specific base salary draw, and then once they hit that draw, they can start getting incentive compensation where it's certain at risk. Another piece of that would be individual performance pertaining to quality. So those are the most common ones that we see from an individual compensation perspective in rural communities. There's also group or specialty pool models. This is most popular anytime you have a situation where you have a lot of global fee billing, such as OBGYN practices, where the group overall, their specialty performance or outcomes create a pool of revenue that is shared amongst the providers in, is it individually based criteria of whatever percentage their contribution is to that pool? Is it the group splits it equally, et cetera? There's a lot of variety on how we set that kind of criteria. Since I use the example of OBGYN, I'll say how you break that up amongst it oftentimes is here it is for GYN where it's global billing, right? And trying to figure out who delivered the baby versus who did all the prenatal visits. Or here's the GYN compensation where it's more usually split evenly amongst the providers. The last piece is what we call stacking compensation. So oftentimes you have already either this group or individual compensation set up and you add something on top of it, right? You stack it on top of it, whether that's call coverage compensation. I will say one area where I'm seeing people get themselves into trouble is around this call coverage compensation. They think, okay, more and more providers are asking to get paid for call. Realistically, I personally would not pay for call coverage unless it is beyond what is considered reasonable. So if you're asking a provider to provide a 1 and 2 call service, and you're never going to bring in locums or any additional providers to be able to help cover that call so they can never go on vacation. I did legitimately work with an OBGYN who provided almost 300 days of call for a group where, they couldn't justify having more than one OBGYN, but they also really struggled to get a locum ever in there or have a PSA to provide any additional call. So for that level of call coverage, since you frankly could never go on vacation, they did do some call compensation. That is appropriate. However, if you have, say, 3 orthopedic surgeons, a 1 in 3 call schedule is very common amongst rural communities for both orthopedics and general surgery. You're rarely going to be able to recruit a provider into a situation of a 1 in 2 call. So you might have that third provider specifically because you can't get that call coverage. You might not ever get those 3 providers up to median levels of productivity. You need it really for the call coverage to be within commercial reasonableness, which means if that's the case, they're not really doing excess call. So paying them specifically for call coverage is usually inappropriate. The other pieces of stacking compensation, the one that most people are familiar with, are both medical directorships and APP supervision. One thing I want to be clear on APP supervision is be very clear in your contract of what APP supervision that entails. How much of it has to be in person of supervision? Do they have to be on site with the APP? Is it just a matter of what percentage of their charts that they review? Do they have to sign off on all their charts? Be very consistent with whatever your state's specific license is with regards to APP supervision. And then for both sides, for both the physician and the hospital or health system, I would be very clear as to how many APPs are covered by that supervision. Frankly, you see, and especially in the family practice, you see up to coverage of 5 APP supervision. After that, frankly, the provider's providing more supervision services than direct patient care, and you might want to think about how do you have that arranged and is it appropriate? Realistically, I usually put in a range of APP supervision in my contracts of, hey, this covers up to 3 APPs, for each additional one, here's the amount that I would pay, depending on the specialty, depending on the responsibilities and the requirements for that supervision. Here's what we pay extra for that. But make sure that's clearly defined in your contract. If you have something that's just as general as APP supervision, and then you say the responsibilities, but you don't say is that 1 APP, 2 APPs, 7 APPs. You get into a place of trying, everybody's going to try to interpret it in their best interest, and it becomes really blurry. And oftentimes I see those contracts really fail in execution because who's overseeing payroll and who has the ability to call up payroll and argue about it, and it gets messy. So that being said, let's go over some of the things, especially the big topic of what CMS did at the end of last year, and also COVID-19 and how that's impacting your contracts. So as most of you might have heard, on December 2nd, CMS published the final rule for the physician fee schedule for 2021. It was probably one of the most disruptive changes CMS has put forth in a significant amount of time. Realistically, we had not had such an overhaul of the work RVUs related to E&M codes since 2007. So the E&M codes were there's been a push from the AMA for a significant number of years. They actually have an executive council that provides guidance to CMS, and there's been a concern about, frankly, a lot of things in primary care, that these E&M codes, 99201 to 205 for new patients, 211 to 215 for established patients, did not really reflect what the ongoing documentation burden was on primary care physicians, that there was a significant time requirements for this, being able to have to track that in doing your coding. It didn't appropriately relate to what were moves in population health and doing multi-system checks on patients to be able to do wellness visits to meet all of their, whether it's ACO standards or if you're participating in MIPS. Or other forms of APMs. We're thinking about the direction that the country is going and what's being required of providers, and these hadn't been updated in such a long time. So rather than their usual gradual rollout that we see, like we saw for MACRA, that frankly has been around since 2015, that people are still talking about what they might do with it, they overhauled it all at once, right? There's some significant changes. One of the big ones was that the 201 code was eliminated, which frankly, if you're doing your coding correctly, that was primarily used for nurse visits anyway. But this has been highly disruptive doing this all at once. When we look at the overall utilization from from these codes that had the biggest changes, and you apply that utilization to the differences, we're talking about an increase in work RVU value for the same codes of 35.8%. So if all you billed were these the new E&M, new and established patient visits, if you had the same utilization as the rest of providers across the country in 2019, you saw the exact same number of patients, you billed them the same way you did historically and did nothing else different, your work RVUs would increase by 35.8. Well, as we were talking about with individual based compensation, where it's based off of productivity, such as work RVUs, which is hands down the most common way to pay for productivity, most of you have not budgeted for a 35.8% increase in your physician spend. I highly doubt it. If anybody did, I would like to know how you had that foresight, and I'm taking you to Vegas. Now, it's different across the different specialties, right? We think about who uses and gets the bulk of their work RVUs from the new and established E&M codes versus otherwise. You think about surgeons, they actually get the majority of their work RVUs from the surgical codes versus the clinic visits. It's really urgent care, family medicine, pediatrics, internal medicine, who are doing a lot of those office visits with patients that are having this huge increase. But we still did see some modest increases across other specialties, such as general surgery. Maybe you did budget for a 3% increase in general surgery, but I highly doubt you would have expected an increase of 20% for your family medicine. So, and then these percentages that I show here are based off of MGMA Data Dive. Every 3 years updates their procedural profile of saying, based off of all the work RVUs that physicians do, here's what percentage of them are E&M codes, and here's the breakout between 99 to 1. And so this is a weighted average based off of specialty. So with that, people, thinking about, okay, changes of work RVUs, well, surely if you're going to increase work RVUs, hopefully we'll also have an increase in reimbursement. But on December 2nd, lo and behold, we did not get an increase in reimbursement. Actually, in fact, we had a significant decrease. We went from $36.09 conversion factor down to $32.41. So we had one of the biggest negative adjustments we've ever had from a conversion factor, paired with one of the highest increases in work RVUs. So that's just been a double whammy factor for those of us who have paid physicians and APPs on a work RVU related basis. You know, that's something that nobody could have foreseen as far as a budget perspective and being able to plan for. Realistically, if you look at the Medicare reimbursement overall, you look at the 203 is the most frequently used code that did get an increase, but it doesn't compare to when you look at the decreases for the second most utilized code, 204, or the decrease of 202s, 11 and 3%. Now, there was a lot of lobbying and feedback from physicians, primarily the specialists. And so under the Consolidated Appropriations Act, they did make an adjustment that the conversion factor was a $34.89. So while it's still a decrease from the 36.09, overall, you know, we put budget neutrality adjustments on hold, and it resulted in a 3.75% increase overall on a weighted basis for the physician fee schedule. Now, that being said, you know, that's for that increase only applies to 2021. So when we think about what we've seen from CMS, you think about going forward, you know, am I going to react to a moment in time, or is this indicative of where CMS is going? Are we going to see further adjustments? Can I kick the can down the road and just kind of deal with this in 2022 because I'm busy dealing with COVID? Those are the kinds of conversations we're having with clients right now. And my response would be, don't kick the can down the road. Have the conversation now. We're going to continue this in this presentation to be talking about what can you do about this? Because frankly, I do see this as indicative of where CMS is going, that we're kind of putting a hold on increases on reimbursement for the physician fee schedule, and we're really readjusting the work RVUs. Will this be the biggest change that we have for a few years? Most likely, but the reality is it's a significant change and it's not going to be undone. We're not going to go back to the 2020 work RVU value rates. So we need to think about that from our contracts. So I've been working with a client that has been, you know, in their scramble. They were like, wait a minute, what are we going to do for our contracts? This is going to be a significant hit. And so I have in here an example with a primary care system. They had a 6-provider group of internal and family medicine that they were working with. It was an independent group. They were under a PSA system where they gave them a specific PSA rate for their work RVUs for providing those services. Right, the group itself does all of does the billing. The hospital does all the collections on that, and they pay a PSA rate that's supposed to cover everything, the physician's salaries, et cetera. And so in 2020, this is by the way a highly productive group. They had just under 60,000 work RVUs. So the hospital wrote them a check for just under $6 million. Now, when the rules came out and we were looking at their CPT codes and said, okay, we know that 2020 was actually a dip, but the group had actually rebounded really well in the fall and got caught up, where 2020 was actually closer to budget than most people than I've seen. So we said, if we just had all these work RVU changes and applied it directly to what happened in 2020, what would be the impact to the organization overall? The increase in work RVUs was from, as I said, just under 60,000 to almost 73,000. So we're talking about a 22.1% increase. And contractually, they had a rate of $98.35 to cover that. They were like, realistically, that would be a $1.3 million of increased compensation if we don't change these contracts in any way for this group here. Most hospitals, like, with all the hits that we've had with COVID, we can't afford to be, taking a $1.3 million hit on these providers. And realistically, in talking with the providers, how much of an increase in expense did they really incur? That the work RVUs are supposed to account for, reduced productivity because of EMR systems, et cetera. Reality was, the group probably needed to hire one more coder to do education and to be doing the double checking with regards to the new documentation requirements with regards to CPT codes, but they didn't really have an increase in expense. So frankly, it was going to be a $1.3 million windfall to the provider group. Now, there are, like, as I mentioned previously, there is increased reimbursement depending on how you, like, on where your code utilization falls. And so we dove into it, and they did have an expected revenue increase of about $607,000. So out of that 1.3, you're still talking about a $700,000 windfall to the providers at the cost to the hospital organization that they still frankly couldn't afford given all of that situation. So what in this specific case, they agreed to let's look at it from a break even, a neutral impact to the providers, recognizing, okay, there's increases in reimbursement. We're primary care. We feel like we've been under reimbursed for several years. That's been longstanding. So, the hospital is going to get that. Where can we get this from a break even perspective? So we did agree to a change in the rate for the entire year, bringing it down to $90.03. In addition to that, we've added in a contract provision that says that we can't, that any time that a change from CMS or regulations would cause more than a 5% swing in expected projected payments, that they would be subject, we would have 60 days to come up to an agreement as to what we were going to do. So bringing both parties to the table to discuss what the changes are, but also to making sure that there was a certain protection in there in case there's further situations like this, where we're going to have a 22% swing in cost to the organization, just to make sure everybody's coming to the table and thinking about it fairly. So, well, before I move on, this example, I think actually, even though it's a PSA agreement, this applies to most of you to think about any of your provider compensation agreements that are on a work RVU value basis. If that's tied to that, hopefully you have already done so, but if you have not, I would put it on your high priority list of doing this analysis of understanding exactly what is this going to cost you. Hopefully, again, most of you guys did this in December, but we were dealing with a second wave of COVID. I know plenty of organizations have been reaching out to us for help to have them figure this out of what should we do, what is economical, but also fair to the providers given COVID. So let's talk about what's happened with COVID. CMS did issue back in March these blanket Stark waivers when it came to the Stark and anti-kickback regulations, right? We talk about having to be at fair market value, commercially reasonable, et cetera. The waivers themselves did not get rid of those requirements, but it gave you a lot more flexibility in certain circumstances. And those certain circumstances, I have them listed here, but you'll note everything is, you have to be able to show that whatever you did to change compensation, or if you kept providers whole despite low productivity, et cetera, it was in response to the COVID-19 outbreak. It was something you needed to do because of COVID. You couldn't use this as an opportunity, COVID as the excuse to give a physician a pay raise if reality was they weren't negatively impacted. If you had somebody who was on a guaranteed compensation because they were in their first year of being a provider in your community, and so reduced volumes didn't impact them, and you didn't reduce their guaranteed compensation, this doesn't apply. Hopefully that contract that you set up initially was already within fair market value and was commercially reasonable, because you couldn't use COVID to say, all right, well, now I'm going to justify a higher than usual base salary if that provider did not. Now, to be clear, when I say it's related to COVID, that doesn't mean the provider had to be seeing COVID patients. So even if a provider, let's say an orthopedic surgeon who was not providing any care to COVID patients, wasn't having to be able to keep that provider in the community and keep them whole, because you were going to lose them, and then it would be excessively expensive to recruit a new orthopedic surgeon into your community because of what was going on with COVID, that is something that falls under this, right? To ensure the ability of healthcare providers to address patient and community needs. Or, from that perspective, your community needs an orthopedic surgeon that you've been able to justify, and he is potentially going to leave because of the low COVID volumes. Keeping his compensation whole is one way of ensuring that your community will have those needs going forward, especially post-COVID. So I just want to be clear that it's not a blanket waiver of saying, hey, if that provider was providing COVID care, therefore you can compensate that, the Stark doesn't apply. Starks does say, that basically you can go outside of fair market value, but again, you have to have a very well documented reason. I'll use another example. Another group we've been working with, they used actually a physician assistant who was primarily an OBGYN, but also in primary care. That physician assistant back in March, led the COVID response. So she stopped seeing patients actively. She was heading up the task force to figure out what are we going to do. She helped set up basically a temporary COVID hospital in where the ice skating rink was in that community, just so that they had that set up. So she didn't see any patients really for the month of March and April. Now, did they have nearly the outbreak that they were worried about? No, but it also meant she didn't see any patients really for a 2-month period. Could they keep her compensation whole despite her contract that said she was going to be paid, here's your base plus work RVU kicker? They agreed to go ahead and say, all right, we're going to pay you, that we're going to keep you up to whatever you were in 2019, despite not seeing as many patients as you did in 2019, because you led this task force for us. That is completely appropriate. You have to document that. You can't just say retroactively and be like, oh, hey, if somebody comes asking, well, this is why we did it. You want to make sure you're documenting this and checking off those boxes, but it would be considered, even though that might be outside of fair market value, some people might argue that's not commercially reasonable to take a provider out of seeing patients, especially family medicine. From that standpoint, maybe she should have been seeing COVID patients, but by documenting it and explaining why you did it, the Stark blanket waiver actually applies for you. So, the whole point of these Stark waivers, to be clear, was to allow you to have these quick responses to the pandemic as long as it's related to COVID-19 purposes. It allowed you to do telemedicine contracts, getting people doing urgent care coverage, figuring out, especially with telemedicine, you might not have had in your agreement that you applied telemedicine work RVUs. How do you do that? But to be clear, nothing about these waivers were intended to weaken Stark. Stark still completely applied. It just allowed you some exceptions during this time period. And while this became active on March 1st, it's still in effect right now. We don't know when that's going to end. So you need to keep on top of what you're documenting and why. All right. As I mentioned previously, when we think about how those waivers specifically work, you might be outside of fair market value. I do want to note that with the waivers, one of the things that allowed that a lot of people have been using, as long as you document it correctly, is a lot of hospitals have actually figured out free services that they could provide to their providers. A lot of people have put their providers in a hotel or somewhere where they're not going home to their children or they're providing childcare, they're providing meals. Technically, those services are compensation. So that's why Stark still applies. And so thinking, okay, it's the right thing to do that we feed our physician staff and our provider staff, that we put them up in a hotel so that they can be quarantined. That provision of housing is compensation, right? It's non-monetary. And some people have in their contracts, specific caps to make sure people don't go over fair market value. But now this would put them over that cap. The waiver would be able to apply and you would be able to apply it there. So just make sure you have this very well documented, especially any expenses related to, quote, free services that would be considered compensation. So given all of this climate that we've been talking about of Stark and anti-kickback applies, we have, we might be all over the place with our contracts. Frankly, what's an organization to do in this situation? How should they treat their compensation? Where do they go from here? Well, let's start talking about, because of the CMS changes that we were talking about, what are the options that people have been utilizing since December 2nd during this kind of scramble? Right. One of the most common ones is they've put into their contract language of saying, all right, we don't know what we're going to do. So as far as from a long-term strategy, so we're going to calculate all of your work RVUs based off of the 2020 physician fee schedule. We're going to forget that 2021 has changed all the work RVU values. We're still going to bill according to the appropriate codes for 2021, but we're going to specifically put into our system, we're going to use Excel, we're going to use whatever our system is for payments. If we have it automated, we're going to override to make sure your compensation related work RVUs are going to be based off of that 2020 physician fee schedule. I will say this is the most common things that organizations did for two reasons. One, it felt really simple at the time. It's the, well, three reasons actually. Two, most providers, frankly, there wasn't time to fully educate them about CMS changes. As I mentioned, we were in a second wave of COVID back in December related to the holidays, that it felt fair to the providers. They said, okay, we've been, organizations have been slammed by COVID. Everybody's at a reduced operating margin. We as physicians, if we're kept held harmless and we're still going to make the same amount of money as last year, thank you, CMS, for the increases, but we're fine. Like, well, we're going to do what's right and let the organization get on its feet and figure this out long term and just make sure we're coding correctly, right? We're not going to be at a risk from that we're not doing coding correction. And that promises you're going to look at this going forward. Let's figure it out. This can't be a long-term solution of just we're going to stick on the 2020 fee schedule forever from that standpoint. And then, of course, most people, frankly, there were several that missed, frankly, could not fully get their heads around what was happening in December because they were busy with COVID, or they were, ready for a break with the holidays, et cetera, that trying to change all of your physician contracts in a 1 month period just wasn't feasible. So we kicked the can down the road. So that's the most common one. Another thing that people did is they said, we're going to apply it for a partial year. We're going to stick with the 2020 physician fee schedule until June, the end of June, and then we'll adopt 2021 for the remainder of the year. That'll buy us some time to figure out what, how is this going to impact us. It's going to minimize mitigate the impact so that the increase only applies to half of the year from that standpoint. And maybe we can make some additional adjustments for the second half of the year that might be fair for providers. And then, it bought us some time. But that's really all it did. It reduced the drastic change for a full year period, and it bought you some time. Or others decided, what, we're going to go ahead and adopt the 2021 physician fee schedule and the work review calculations, but we're going to have to adjust our contracts otherwise. Whether it's we're going to adjust our productivity incentive threshold to say the provider got a bonus after 5,300 work RVUs, we now need to increase that to 6,100, whatever the calculus was. Some people did a very detailed analysis. I think this is what I actually spent most of December doing, was these detailed analysis of what a new threshold should be or what a new conversion factor should be to keep things neutral. Because this allows you to basically have this live on for potentially future changes in contracts, right? Or from CMS, so that it grows with it. But it is a lot of analysis depending on the sophistication of your organization. The vast majority of the services that you're doing, most people had to do this on an either individual provider basis or across their different specialties. And so based on your capacity level, most people did not go this route unless they use somebody else to do the analysis. Or, as I said, or you could adjust both. Most organizations that I work with that have actually taken this approach, what they did is they changed the incentive thresholds. Others have been doing both the incentive thresholds and the work RVU compensation conversion factor. The reason why most organizations that have adopted the 2021 physician fee schedule did not only adjust the conversion factor is because, frankly, the education necessary for the providers to understand that change was too high of a hurdle. That looks too much of like, hey, you're cutting my pay. If you're going from paying $45 per work RVU to paying $32, that's a big shock to the physician, and not being able to do the walkthrough of how that might actually be a hold harmless was not something that most organizations we were working with were ready. They didn't have the attention of their providers to go through all that education. So for some reason, incentive threshold changes was more palatable than changing the conversion factor. Even if it has the same net effect, it's just an education and a language aspect. But here's what I would say, that when you think about, okay, here's what I'm going to do for 2021 and dealing with this change, it raises the larger question about compensation strategy. Do your contracts have protective language to be able to have the ability to negotiate when there's a big change like this? A lot of contracts don't, especially if you don't have uniform contracts across your organization for the provider. It becomes really problematic if you don't have that kind of protective language that says, hey, I can renegotiate or readjust compensation in these situations. So go through and make sure that you do have that protective language in there, and so that you can be prepared for potentially future CMS changes. And then also, if you haven't talked to your providers or have a good alignment with your providers about compensation historically, you can imagine with these changes, it's going to be even harder to have that conversation now. So it's raised the issue of how do we as an organization talk about compensation with our providers? How involved are they right now? And how can we adjust that going forward? With regards to the COVID waivers, what I like to do is do a checklist to see whether or not any of my contracts are actually at risk for this. So here, and I know that these slides will be available for you guys to download. I would go through for each one of your providers and use this checklist of questions to ask to see whether or not you need to evaluate and properly document to make sure you're covered by the waiver. So if the answer for, and like I said, I would do it on a provider basis of just ask these questions, yes, no, very simple. If the answer for these are yes, then I would go, then the Stark waiver might apply. And it would be like, what do I need to document to make sure I'm just covered for that waiver, and make sure that that waiver is in place and documented in the physician file. I don't have to look at it again unless somebody comes knocking, but that way I know I'm covered, right? And then let's have a conversation about compensation going forward. A lot of groups, COVID has highlighted that those who are on more value-based contracts and who were paid more under capitation and had our providers actually have at-risk compensation based on value-based fared better during COVID than those who were not. Having that set revenue, understanding what was coming in, not being so dependent on volume from a fee-for-service perspective, did put people in an advantage. But this conversation has been going on longer than COVID. Those of you who are in an ACO or have an APM and are looking at, okay, this is how my organization is being reimbursed, oftentimes to be able to achieve those or that organizational goal and get that enhanced reimbursement or those shared savings has actually required significantly more work on your providers. And we have more and more providers asking, where's my piece of that pie? You have me doing X, Y, and Z. Where's my compensation for it? I'm still paid entirely on a fee-for-service basis. Especially if your only incentive is based off of productivity. So I would say you need to think about where is your organization on its transition to value. If you're currently getting paid for value, are you paying your physicians for it? I have a hard and fast rule when it comes to compensation that I don't pay for what I don't get paid for. So your compensation contracts really need to be aligned with your overall organizational strategy, and they should have the ability to adjust as your organization does of how it's getting paid. The more at risk your organization is, the more at risk the physician compensation structure should be. So think about where your reimbursement is right now, what percentage of it is tied to any value, what percentage of your total revenue is tied to getting any quality payments, how much of it might be at risk now versus how much is just an upside agreement from a shared savings versus what's going to be at risk in the future. And think about, okay, how does this compare to my physician contracts? Do they mirror one another? Usually the contracts are going to lag behind by at least about 2 years. However, they should be prepared to adjust. If you're not having that conversation with your providers now, you most definitely need to be. If you know that you're on the path to transition to have some sort of value-based compensation and your providers are paid base salary only and it's guaranteed, you are worlds apart and you need to start making the adjustment to how can we close that gap, right? You have to think about, okay, what are the administrative duties that I'm putting on my physicians that help me, report to my ACO from that perspective, and how am I paying it for them? Is it something that I set up a medical directorship agreement and put all these responsibilities to help launch an ACO, and now I'm still paying for it, but we're 3 years in? The reason administrative duties are not the same. Starting something versus maintaining something do not deserve the same amount of payment. So have you re-examined your contracts for something of that nature? Keep in mind that the quality incentives, especially for MIPS, a lot of organizations say, okay, well, we've agreed upon these 3 quality incentive payments, and now they're in the physician contract. Well, again, achieving a certain level of quality is not the same as maintaining. So are you constantly adjusting, either increasing what the goal is or adjusting it to what is going to move the organization forward. If you had status quo, say you've hit, a fantastic outcomes and patient satisfaction scores, and you're just going forward and doing the same thing year after year. Is that enough to justify that compensation for that provider from a quality incentive? Or should you say, okay, what are our new things that are coming up that we need to be paying attention to? How do we incorporate those? Maybe it's time to shift what are the quality incentive payments that we have outlined in our contract. And just as a reference point, right now, I would say 10% of total base salary is about the appropriate amount to put for quality incentives, especially if you are doing upside only of saying, hey, you get a bonus for hitting this quality incentive. I would do no more than 10%. I see a range of 10% for those who have both positive and negative adjustments for quality incentives. So their base could go up 5% or down 5% based off of hitting quality metrics. Those are becoming more and more prevalent, especially for those who are participating in MIPS, where you have both upside and downside adjustments to your reimbursement by hitting quality. So your contract should mirror that. You start having physicians at risk. I'm begging of you, don't get off of this webinar and go and announce to your provider staff who have never been paid on quality of saying, hey, by the way, now you're going to go at risk and you're going to have negative adjustments. That's why I say contracts for providers usually lag about 2 years behind where the organization is, because it takes some education and some buy-in to be able to move that forward. I don't want anybody going back to their organization today and blowing up their medical staff by saying, hey, we're changing all of your compensation. Pay attention to what the competition is doing. What's Integris doing in the market? What's Ardent? What's Northeastern Health System? What's going on in Oklahoma? Because fair market value in Oklahoma, in a specific town, is not going to be the same as it is in Texas. It's not going to be the same as it is in Nashville, Tennessee. You have to pay attention to what's going on specifically in your market. If, a lot of the groups have best practices that they use for recruiting providers. If it's Integris, does a lot of stuff with regards to their benefit plans for their providers. And so understanding that helps you be more creative for how you structure your incentive and getting away from just simply saying survey says X and only applying that. Some things to think about going forward is, especially with COVID that has compounded this, is thinking about some upcoming retirements that you have. Is this an opportunity for thinking about your succession planning and looking at, I've been in several organizations where the contracts have been sitting there and unchanged for 15 years, right? Or for as long as the provider has been there. You didn't want to upset the apple cart. Maybe you have new administration in who's realizing that the administration that had been there for 20 years, had a handshake agreement. They did put it in writing, but the compensation really hasn't changed that much. Is this an opportunity for you to think about your relationships going forward and setting that compensation? With COVID, we have a huge increase right now in employment of physicians rather than independent practices. We have them selling their practices to the hospital. If you're thinking about your RHC alignment strategy, is this an opportunity to involve those independent practices and think creatively about how we're going to compensate them, right? If you're buying up an RHC that's already been grandfathered in, is this an opportunity to think about how that contract is going to work with those providers? Keep in mind, again, a lot of the Stark and anti-kickback focus is going to be on non-clinical arrangement agreements. There's increased pressure. Most physicians are asking for more money for call, asking for more money for directorships, et cetera. But that increases the level of scrutiny that they're getting from the OIG for Stark and anti-kickback. So you have to be really careful about those agreements and don't just say, okay, well, it's what my physician asked for. It needs to be a conversation. You need to do some due diligence. It can't be a simple matter of keeping the providers happy or so-and-so did it, so therefore it's fine. And again, pay attention to, has COVID caused your organization to accelerate more towards the value-based care model from a reimbursement standpoint? And if that's the case, where you're in your compensation, as I said, if you're all on guaranteed salary, you have a lot of work to do to move towards any sort of at-risk compensation for your providers. So that's something I would examine. Another piece to finish up here, because I know we're running out of time and I want to have a couple minutes for questions, is make sure, just like mask wearing and washing your hands, your contract compliance is about good hygiene for your organization. document things. So much of what I do when I'm doing valuation work is, frankly, it's a documentation exercise. It is making sure I have my ducks in a row, that I can tell the story of why did we pay this provider this amount. Oftentimes, things such as difficulty recruiting, a position being open for 400 days to be able to get in a new provider, the competition in the market. If you don't document that in real time as it's happening, 5 years down the road when the agreement actually comes into question, because it rarely happens, the year you execute the contract, you don't remember what was going on. You don't have the same people in place to say, oh my goodness, we interviewed 20 people for that. We just couldn't get anybody to come into this position. So we had to put in a $30,000 premium onto the base because we couldn't recruit anybody. Nobody remembers that 5 years ago, especially if somebody's departed the organization. So that documentation is absolutely critical. I like to have an overall compensation guideline for my organization that I work on with the providers to set the parameters and set the guardrails so that if you're going to have an outlier, you have a very specific reason for that outlier. But frankly, it makes negotiation a lot easier of saying, here are parameters that the providers have agreed to. So I don't want to go outside of this. So when you have somebody saying, actually, I need to get paid for every single time I get called into the emergency department, that's outside of our guardrails. That doesn't seem overall fair. And it helps you ease those negotiations and not put yourself in a position where, frankly, the CFO or the CEO are always the bad guy saying no to the providers. So it's really important to have those providers at the table when you put those guardrails in place. You need to identify your high-risk contracts. I know I've hammered a little bit on the surveys and saying, being anti-survey says, but you can use your surveys where you have a greater degree. I would say if you have definitely more than 20%, but if you have a more than 10% gap between what the productivity percentile is and the compensation percentile, I would flag that as a high-risk contract of saying, okay, where's my documentation? Do I have a fair market valuation in place for it? How did this come about? Do I have all my ducks in a row? And making sure you have that for those cases. And then create a contract audit policy. Make sure you're going to be reviewing these on a regular basis. So that being said, here's my contact information if people have questions about this. I know we've covered a lot or want to talk about their overall compensation strategy and how to move it forward, especially if you are somebody who is listening and says, oh, all my contracts are on guaranteed compensation, and that might be a problem. So I don't know if we have any questions. I know we're pretty close to time, but I'll stop there.
Thank you, Opal. I've been watching the chat. So far, we don't have any questions. We just had one about the slides, and we will have the slides available and send those out after the webinar. Are there any questions? That was a lot of really great information.